A lot of the information in that pharmacodynamic chapter from then on will be shown to you as curves, as graphics, which makes it very amenable for USMLE Step 1 question as usual. First type of curves, the dose response curves or DR curves. All they're plotting, if you look at the one on the bottom left of the diagram, is the amount of drug given as a log dose of drug on the x-axis, and it's relating that dose with the percent response on the y-axis, essentially telling you we're looking at a diagram of efficacy of responses. In the first diagram, we show you two drugs, drugs A and drug B, and we show you clearly that both drugs, as you increase the dose, eventually cause more and more responses, ultimately giving 100% response. This is what we refer to as a full agonist. A full agonist is a drug that can eventually give 100% response. There's a difference between A and B. Although they bind to receptors and give similar responses, A and B do not do so at the same doses. Notice that you always need less of A than you need of drug B in order to get the same size response. That's a sign that drug A must be more potent than drug B. You need less of drug A than drug B to get to the same size response. Take an example. For a 50% response, you would need this much drug A. For that same 50% response, you would need this much drug B. Obviously, a larger amount than you would need it of drug A. So how could we recognize our parameters here? Well, certainly for drugs A and B, you can recognize that they must have had some affinity and bound to receptors. And one thing we do, which is not very correct but applicable for board question, is to decide that the drug that is more potent must be the one that binds the best, the easiest to receptors. Thereby, we'll say that drug A, the one farthest to the left, which is more potent than drug B, is also the one with higher affinity. You know, that's a dangerous game to do, since it is taking for granted that A and B are really working on the same receptor, and you're comparing binding to same types of receptors for the type of response that is seen. Nonetheless, in a nutshell for your exam, if curves are nice and parallel, such as that first diagram we're studying, then the drug closest to the y-axis is both the highest potency and highest affinity drug of the ones represented. How about efficacy? Now, efficacy, certainly you can always assess when you look at a drug response, when you look at a dose response type of curve. For instance, you notice that both drug A and B eventually reach 100% responses. It means A and B have similar efficacy. So where are the tricks in there? Well, there are two types of tricks. The first one is shown to you with the graphic that's to the right. When you look at the graphic to the right, drugs X and Y, as log dose response curves go, first point you would notice is drug Y does not reach 100% response. That is what we call a partial agonist. Partial agonists are drugs that do not give 100% response, rather they give partial responses. They have a ceiling effect. We'll talk more about them in a little while. Nonetheless, it does mean that if I look at response amount, drug X has the highest efficacy, drug Y has less efficacy. How about potency? Well, depending on what size response I'm looking at, let's say 50%, why not? I would need less of drug X than I need of drug Y to get to 50% response, so X is more potent. As a matter of fact, no matter the size of response I'm seeking, drug X is always going to be more potent than drug Y. Your big issue in that graphic is the fact that the slopes of curve X and curve Y are not parallel. And when slopes are not parallel, your trick is you should not answer any statement relating to affinity of the drugs for receptors. You see, here's a way to remind us on the exam that what you're really plotting is percent response, not percent binding. And when it comes to responses, we may achieve similar responses by binding to very different receptors. I'll give you an example. If you want to vasodilate, well, to vasodilate, we'll see in the ANS, we could bind a beta-2 receptor. But you know as well as I do that bradykinin, by binding to bradykinin receptors, you know that drugs that release nitric oxide anything that would block a calcium channel, drugs that would work on certain serotonin receptors. All these different targets can result in the same vasodilation response. The way we know that different receptors are being used by drugs in achieving those responses is by looking at the slope of the curves. And when the slopes are not parallel, this is an indication that X and Y are not using the same receptors. From there, obviously, you're trying to compare the affinity of X and Y becomes irrelevant since they do not have the same target. So you cannot answer about affinity when curves are not parallel. On the left, the slopes of A and B were parallel. You were totally allowed to answer points about affinity then. Although we've already defined full and partial agonist, let me remind you on your computer screen appropriate definitions. A full agonist is a drug when it binds to a receptor capable at the appropriate dose of giving a maximal response. A maximal response. That full agonist producing a maximal response means it can give 100% response. A partial agonist is incapable of eliciting a maximal response, only gives partial responses. If you want, let me quickly draw for you a little axis about agonist, antagonist, and partial efficacies. Imagine the following axis. Zero effect in the middle, an effect of +1 at the top, -1 at the bottom. If you wanted to put your drugs, an agonist is a drug that gives a response, and we call a full agonist a drug that will give you a response of +1, if you want on my diagram. What would you call a drug that gives you a response of 0? No response at all. That's what we call an antagonist. Antagonists sit right here with an efficacy of 0, leaving you therefore with -1 right here, a class of drug we seldom talk about, but you want to be aware of because you'll probably ultimately hear about them sometime in your lifetime. When drugs give responses, but these responses are the opposite of what you would expect, then they're simply called inverse agonists. Notice therefore a key issue here we've established initially is don't confuse antagonists and inverse agonists. Antagonists have 0 efficacy. Inverse agonists are the one that would give a -1. So where are the partial agonists in here? Partial agonists is anything in between. You call partial any drug that can give responses but never give +1. A partial agonist would be right here. An inverse partial agonist would be down there. For our pharmacology, we basically focus on the top of this diagram. Let's look at this now in graphics. If you look at the graphic entitled Efficacy and Potency of Full and Partial Agonist, you're seeing 3 drugs. The drugs are labeled A, B, and C. As you look at these drugs, you recognize drug B, a full agonist capable of eliciting 100% response. You also recognize 2 partial agonists, drugs A and C. Those are drugs that give a certain amount of response, never reaching a maximum. Here in our example, it seems like both drugs A and C would result in, at best, 60% response, what we call having a ceiling effect in the therapeutic activity of drugs A and C. Are the curves parallel? Are the slopes parallel? Well, when you observe the diagram a little bit, you notice that the slope of drug A is parallel to the slope of drug B, parallel to the slope of drug C. Therefore, can you compare parameters of affinity? The answer is yes. Because the curves are parallel, we'll take for granted that all 3 drugs bind to the same receptors in order to give whatever response is being plotted. As a result, you remember that the drug closest to the y-axis is the one that has highest affinity. Drug A has the highest affinity, C the lowest, B intermediate. How about efficacy? Efficacy, we remember that we can always answer parameters of efficacy by looking at log dose response curve, since efficacy is the amount of response given. And from the example in the diagram, drug B has the highest efficacy, it's the full agonist. Drugs A and C have same efficacy. They can give the same amount of response, and in both instances, The efficacies of A and C are less than that of drug B. Now comes the issue of potency, and that's where there's a little trick on the exam again. That trick relies upon the fact that a lot of us will remember in pharmacology defining potency for a 50% response. Let's try this first, since it's the conventional way of looking at potency. For a 50% response, which of the three drugs would you need the least of in order to achieve that response? Well, as you draw a line from 50% onward, you notice that drug A is the one that you would need the least of to get 50% response. From this, should I say a general statement such as drug A has the highest potency? You might be fairly comfortable with this. Yet, let me play the devil's advocate a little bit and let me ask you, what if I wanted to achieve 80% response? Is drug A still the most potent for 80% response? Obviously, if you follow an 80% response line, drug A never reaches 80% response. Drug B does. So now who becomes more potent for an 80% response? Drug B actually can be more potent than drug A for responses that are in excess of the ceiling effect of the partial agonist. As a result, if the exam was to give you statements to match to a diagram such as the one you have in front of you, be very careful about statements about potency when you have partial and full agonists drawn, since you know that potency is the amount needed for a certain size response. If it is not specified to you, the size response, you know that saying A is more potent than B or A is less potent than B is both true and false. So quite likely may not be the best answer. For instance, if I tell you B has highest efficacy, that would be the statement to take. This is always true. If I tell you A has highest affinity or A and C have same efficacy, all those are absolute statements that are always true. But if I tell you A is more potent than B, it's only partially true. It's only true for the realm of 60% responses that drug A could give. Does it mean saying A is more potent than B is never the answer on my exam? No. It all depends on what other choices are given to you. If all the other choices are wrong, imagine they tell you B has highest affinity and it's not the case, then it's possible that the last statement you find that's correct is to say A is more potent than B. So it's a little bit of an issue, but once you sort out those definitions, you should be fine in figuring out which statement matches best the curve you're looking at. To summarize, 2 tricks with log-dose response curve. If slopes are not parallel, don't answer anything about affinity. And when there are partial agonists, particularly when partial agonists have higher affinity than full agonists, be very careful with statements about potency. Let's develop a little bit more the notion of partial agonists. We've already defined well that a partial agonist is a drug that binds to receptor and does not elicit a maximal response. What is the relevance then of giving drugs that don't work at 100%? Well, you know, one key relevance is when you have a ceiling effect in your response, you are much less likely to result in toxicities, since you can never get too much of a response. However, a disadvantage of this is maybe you don't reach enough effect for the patient you're treating with the partial agonist. Nonetheless, it could be construed as an advantage to potentially have less toxicity. After all, we don't necessarily need to give drugs at doses that give 100% response to have a therapeutic effect. But much more relevant than this, and shown to you in the diagram entitled Duality of Partial Agonists, is the fact that partial agonists have 2 very different behaviors in our body. One, that is the partial agonist alone, shown as the solid line, is that of a drug binding to receptor, and the higher the amount of that drug, the more responses, until a certain ceiling maximum here, in that example of ours, being around 50% response. But the other issue is, what if there is a full agonist already present in the body? The full agonist, when bound to the receptor, gives 100% response. And as you increase the dose of partial agonist and replace the full agonist by partial agonists in the receptors, those full responses will decrease in presence of the partial agonist. They'll decrease to the extent that a partial agonist will behave really as a blocker of responses in presence of full agonists. A partial agonist, therefore, has duality. It behaves as an agonist alone. It behaves as an antagonist in presence of a full agonist. Now, does it have a ceiling effect in its blockade? It certainly does, since eventually when the partial agonist has totally replaced the full agonist in the receptors, you will still see a response, that of the partial agonist alone. Therefore, we'll say there is a ceiling effect also on the blocking activity of partial agonist. Now, if the diagram didn't help, let me give you, if you want, an analogy to this. I'm sure some of you at home or somewhere have seen those little rheostats that we use to regulate the amount of light in a room. Imagine that you get into a room that's all dark, there's no agonist binding to the receptors, there's no light at all. If you're a full agonist, you're turning the knob completely and you have 100% light in that room. If you're a partial agonist, you're turning the knob only a little bit and you have a little bit of light, but you still have light. You have an agonist activity, simply not full. Now, of course, the fun portion of a partial agonist. Imagine you enter that room and there is already full bright. Then as you put your partial agonist, you will actually decrease the light. You won't decrease the light all the way to the point of being in total darkness, just you will achieve dimming the light. Let's put this in clinical words now. When I know a good example right now that would probably fit all of us very well. Do you suffer from anxiety? I'm sure just thinking about the exam or the number of hours in front of a tape, you're probably very anxious. When you're anxious, you tend to have big flare-up of key neurotransmitters in your brain, such as serotonin, norepinephrine, making you quite irritable, quite panicky, not being able to sleep, and so forth. Are you also depressed? Now, you don't have to tell me yes, but if you do feel depressed, at the same time, you remember that depression is exactly the opposite. In depression, you have far too little of those same neurotransmitters. So now comes a big quandary of our medicine. If I want to treat depression, I'm going to give antidepressant that would raise the neurotransmitters and now make me feel very anxious, very irritable. By the same token, if I want to treat anxiety, I'm going to give CNS depressant to lower these drugs. To the extent that antidepressant should cause anxiety as a side effect, anxiolytic should cause depression as a side effect. So what am I going to do if I have both problems at the same time? Think of a partial agonist. If you were giving a partial agonist during the period of time where you have anxiety, that drug could behave as literally an anxiolytic, diminishing the excess effect of the full agonist in your brain. By the same token, it'll never diminish those responses to nothing at all, such as a blocker would, since partial agonists have a ceiling effect. You would only bring back to a more normal level those neurotransmitter responses. At the same time, imagine the next few hours you now feel fairly depressed and down. The partial agonist in these conditions may now behave more as a stimulant and try and become antidepressant. It'll never give enough response in and of itself to cause you to re-become anxious, but really allow you to modulate responses in your body just the same way as we modulated the amount of light in a room with those rheostats. That's why from then on, every time we'll describe a drug as a partial agonist, it will always be a high yield point on the exam, since clinically it'll mean a drug that has duality of action, that can behave both as an agonist and as a blocker. I would not be complete if I wouldn't finish this with another critical example. Imagine a postmenopausal woman with a breast cancer. Imagine further that the classic lobular or ductal carcinoma of the breast has been typed by a pathologist as being very high in estrogen and progesterone receptor responses. ER, PR, positive status, maybe 4 or 5 pluses on your sheet, on your answer sheet. Then in that situation, a classic drug to use would be a drug that blocks estrogen receptors. The classic drug to use, as you know, is tamoxifen. Tamoxifen is a partial agonist of estrogen receptor. It has quite a relevance in that postmenopausal body, since in the breast cancer, it will behave as a blocker, but at the same time, in the bone of the postmenopausal woman, since there is a direct lack of estrogen, it will behave as an agonist and at the very same time prevent osteoporosis. So there again, just to give you yet another example of the role and duality of partial agonist drugs that can modulate responses. Final example of log dose response curves for your exam. Those curves that we often associate with questions dealing with biochemistry, really. Indeed, when we talk about affinity and responses, there is a great parallel with the Km, parameter of affinity for enzyme kinetic, and the Vmax, parameter of amount of metabolism, for us amount of response from drug receptor binding. And therefore, a classic issue is to show you a control curve here on the diagram as a boldface type curve, representing a certain drug and its response, and then superimpose to it a number of curves either shifted to the left or to the right, and asking you what has to have happened to the control in order to result in those shifts. Let's first work with the one shifted to the left on your diagram. You notice that whatever happened to my control drug, when I shift the curve to the left, I now need less of that drug to get to the same size response. Essentially, you would tell me that looks like the drug has more potency. And you would be correct. That's why we call that potentiation. Potentiation is always seen as a shift to the left of the curve. Now, if I want to give you one example that is not pharmacological right now, since we haven't seen names of drugs, maybe some of you remember hemoglobin saturation curves in physiology. And hemoglobin saturation curves simply look at the oxygen binding to hemoglobin, the protein, and a shift to the left shows you better binding, higher affinity for oxygen. Well, equivalent to this for drug, potentiation is a shift to the left. It looks as if it has better binding, better responses. By the way, what is the example that shifts to the left the hemoglobin saturation curve? Hopefully you're thinking carbon monoxide and cyanide, which tends to increase the affinity for oxygen by 200 to 300 fold, trapping the oxygen on the molecule and resulting in systemic hypoxia of tissue. Conversely, any shift to the right of the control curve shows you that now you would need more of that drug to get an actual response, essentially telling you there must be something antagonizing my responses, and any antagonist would be understood as interfering with a control drug and preventing it from giving responses. There are two forms of shifts here. A pure shift to the right, giving rise to a curve that reaches the same height, would be due to what we call competitive antagonism. We explained this very well in biochemistry. In competitive antagonists, the drugs bind to the same site on the receptors and therefore compete with each other. Because blockers have no efficacy, as blockers sit on the receptors, they prevent the agonist from giving responses. However, because they compete, as I increase the control drug amount, I increase the probability of the control drug being in the receptor and restoring the actual responses I saw before. Effectively, in competitive antagonism, a parallel shift to the right, all I seem to have changed is again affinity. It looks now as if my control drug has lower affinity for the receptor. Contrast the other mode of antagonism referred to on the diagram as non-competitive. And in biochem and pharm, there are two ways of being non-competitive. Classically, you could be binding irreversibly to the receptor or the enzyme. Therefore, you can't compete for it. Once the blocker is on the enzyme or receptor, that receptor is lost forever. Or you bind to another site from the one that is bound to by the control drug, in which case they can compete for each other. In either situation, non-competitive antagonism results in a decreased efficacy, a decrease in the number of receptors that can respond. As a result, it is not so much a change in affinity, it's going to be a change in height of that curve that will be seen with non-competitive antagonists. We'll give many examples, particularly in the autonomic nervous system. And as we see examples of drugs, I will make curves for you so that we can try and work out both questions that are relevant. Right now, it would be a little silly to try and imagine names of drugs and receptors to match to these diagrams. All I want you to have reviewed carefully right now is a recognition pattern. If you look at a control curve and you see a shift to the left, there is potentiation. If you see a shift to the right, there is antagonism. If the shift is parallel, it's competitive. If the shift results in a decreased efficacy, it's a non-competitive antagonism. When it comes to antagonism, there are different ways of antagonizing responses. Now, of course, the classic one, which we've just worked on, is what we call pharmacologic antagonism. Essentially, the same receptors are being used by the antagonist and the agonist. And we know they can compete, or they may not compete, simply by binding to another site, allosteric, or by binding to the same site but being irreversible, covalent binding, for instance. Let's leave this one on the side, and let's rather look at another classic way of antagonizing responses known as physiologic antagonism. Physiologic antagonism involves two agonists, two drugs that cause responses, but they work on different receptors. And imagine that one drug has an effect, such as vasoconstriction, whereas the drug binding to the other receptor has an effect of vasodilation. There is no doubt then that when you give a constrictor with a dilator, you may end up with antagonism in the responses and see no more responses at all. That's what we call physiologic antagonism. Great example of physiologic antagonism exists in our body. That's why it's called physiologic. For instance, in biochem, insulin versus glucagon. For instance, in pathology, you would look at things like coagulation versus anticoagulation. You know, things like fibrin versus plasmin. And for us in pharmacology, if there's one good spot to look at physiologic antagonism, it will be the autonomic nervous system with sympathetic versus parasympathetic nervous system. So much more to come in physiologic antagonism. Other potential antagonism is chemical antagonism. Chemical antagonism occurs when two drugs interact with each other and cancel each other's effect without using any receptors. You know, for instance, antidotes in toxicology often work by chemical antagonism. A critical example to know well on the exam, we'll see in the blood drugs toward the end of the tape series, would be to use a drug such as heparin, encounter bleeding from heparin, and administer subsequently protamine in order to chemically antagonize the excess of heparin. So chemical antagonism is also relevant. Really, there's all kind of antagonisms. Those are the most relevant one. Potentiation we've already referred to, and we'll see examples throughout the syllabus. Well, this finishes the classic dose-response curves.